Today, what I want to talk about is anaphylaxis, and I apologize that I'll be presenting today in English rather than in Spanish. I have no conflicts of interest, and these are my objectives. We all know that anaphylaxis is a sudden, severe, and potentially fatal systemic allergic reaction. It can occur very rapidly, and we must learn to quickly recognize it and then initiate treatment because this can be life-saving. In a 2006 article that I think should be in every allergist's library, Dr. Estelle Simons called anaphylaxis a killer allergy. But more importantly, she pointed out that we have to be concerned about long-term management of anaphylaxis, and she emphasized the team approach to care. And she created this two-triangle model for treating anaphylaxis. In the red triangle is what happens in the emergency room or the acute care clinic where we have to recognize anaphylaxis and treat it. But the allergist typically lives out here in the blue triangle where we try to assess the risk and reduce that risk to our patients and provide education. Anaphylaxis has been very prominent in the literature recently. In 2017, we had a specifically emphasized anaphylaxis journal in the Journal of Allergy and Clinical Immunology, looking at the research behind anaphylaxis. And one of the things that we know is when we look at the epidemiology of anaphylaxis, we just don't know enough. Dr. Wang and colleagues in 2019 did an analysis of the global incidence and prevalence of anaphylaxis in children. They did a systematic review and found 59 articles, but look at the variance that they found from 1 to 761 per 100,000 person years. And the data they received was only from the countries that you see marked in color in the map. This should change. We're all typically on ICD-10 right now. When ICD-11 comes out, it will allow us to more appropriately delineate our anaphylaxis cases. ICD-11 has a section entitled Allergic and Hypersensitivity Conditions. And this is in a new immune system disorders chapter in ICD-11. This should help us provide both a global standard for comparability for anaphylaxis and help us to capture the cases of anaphylaxis that we have. We know that anaphylaxis comes from mast cell activation and the release of mediators to include biogenic amines, lipid mediators, cytokines, and our enzymes. But what we see is that the release of these mediators causes the signs and symptoms that we know for anaphylaxis. Symptoms that involve the skin with hives and swelling, the respiratory tract with cough, shortness of breath, wheezing, and chest pain, the GI symptoms of nausea, vomiting, diarrhea, cardiovascular systems that include dizziness, lightheadedness, drop in blood pressure. And we often forget about the neurologic signs of anaphylaxis that include anxiety and what is typically called a feeling of impending doom. And those symptoms come from immediate mediators and late phase mediators. And so when we see anaphylaxis, we have an immediate phase of anaphylaxis and then a late phase of anaphylaxis. But don't confuse the late phase of anaphylaxis with a biphasic allergic reaction. So a biphasic allergic reaction is a second reaction that occurs after the patient recovers from the first reaction. And this typically only occurs after severe reactions for anaphylaxis. So it doesn't typically occur without initial hypotension or airway obstruction. And this typically occurs 6 to 12 hours after the initial reaction. But I think what's important and what Dr. Simons pointed out in her article was that the approach to anaphylaxis has to be a multidisciplinary approach. So there was an interesting meeting in the United States in 2012, and it was called the Partnership for Anaphylaxis, Enhancing Recognition, Treatment, and Outcomes. And so this was a meeting of allergists, immunologists, pediatricians, internal medicine doctors, emergency medicine doctors, family practice doctors, nurse practitioners, and even non-physicians who were part of the managed care company. And that after they met and they talked about these issues, the data that they came up with was shared in a supplement to the American Journal of Medicine in January of 2014. One of the most important things that they came up with was the fact that anaphylaxis is often commonly misdiagnosed as a milder allergic reaction and treated with antihistamines rather than epinephrine. And so there are articles in that supplement were articles like this one, Anaphylaxis, Underdiagnosed, Underreported, and Undertreated. And I would have added and underappreciated, and an article about the recognition and first line treatment of anaphylaxis. And what was important was that when we look at the treatment of anaphylaxis in the United States emergency rooms, a number of studies have shown that up to 57%, more than half of the patients who meet the criteria for anaphylaxis don't get the correct diagnosis. And it also showed that we had undertreatment of anaphylaxis in our emergency rooms. And what I find appalling is we showed in these studies that anaphylaxis patients were more likely to get antihistamines and or corticosteroids than they were to get epinephrine. Now, the use of epinephrine was higher if the diagnosis was appropriate, but even then, not every patient received epinephrine. And then when we looked at the discharge instructions that those patients received as they left the emergency room, less than 30% received a prescription for at-home epinephrine. Less than 40% were told to avoid the allergen that caused the problem in the first place, and less than 20% were referred to an allergist. And even in those cases where patients were given prescriptions for at-home anaphylaxis or self-injectable epinephrine, between 33 and 64% didn't fill the prescription. Now, that's just not a problem in the United States. There was a survey done in 2017 of Latin American countries. This was a survey of 10 countries, and they received 10 responses. 5 of those 10 countries had country-based clinical practice guidelines for anaphylaxis, and Argentina and Brazil have adrenaline autoinjectors. The use of adrenaline, though, in this survey was almost the same as the United States, with the use of adrenaline below 50%, and the fact that patients who were treated for anaphylaxis were more likely to get antihistamines or corticosteroids than they were to get epinephrine. There was also in 2017 this journal from the Journal of Allergy and Clinical Immunology in Practice that looked at ways that we can improve care of individuals with anaphylaxis. And as we've had more focus on the treatment of anaphylaxis, what we see is we're updating our guidelines. So the World Allergy Organization had their 2015 guidelines for the treatment of anaphylaxis, and the 2020 World Allergy Organization guidance for anaphylaxis is currently in the final stages of review and should be out this year. The American practice parameters for anaphylaxis were updated in 2020, and that update was based on a grade analysis. In Europe, with the EACI guidelines, they are scheduled to be updated in 2020, but the current guidelines date from 2014. And I particularly like the EACI guidelines, and I like them because of this particular figure. This figure makes it very clear that the first line treatment for anaphylaxis is adrenaline or epinephrine. And if you look down here, third line, consider antihistamines or consider glucocorticoids. So the first line intervention for anaphylaxis is adrenaline or epinephrine. IM adrenaline is the first choice for anaphylaxis. We give that injection to the mid-outer thigh, and in those countries where we have auto-injectors, we shoot the auto-injector right through people's clothing. The dose is, of course, 0.01 milligram per kilogram, and various countries have various strengths of auto-injectors. In the United States, auto-injectors come as 0.1 milligram, 0.15 milligram, and 0.3 milligrams. And the use of epinephrine can be repeated after 5 minutes. The problem is, though, that patients are confused. Now, clearly, some patients don't even pick up their epinephrine, and even the patients who pick up their epinephrine don't always use it when they need to. It's not unusual to have a patient come into the clinic, tell you about having a second episode of anaphylaxis, and when you say, "Did you use their epinephrine?" they say no, because they were afraid to. And part of that is our fault. We told patients that if they use epinephrine, they have to go to the emergency room. And some patients hear in that epinephrine is so dangerous that if you use it, you need to go to the emergency room. So we need to be very careful about saying to patients that epinephrine treats all aspects of anaphylaxis, and it is your bridge to take you to the emergency room. So patients have to understand the importance of epinephrine. And even those who do carry it, they can't always show that they use it appropriately. And I used to ask my patients after I prescribed them epinephrine, "Do you have the epinephrine with you at all times?" And invariably they say, "Oh, yes, doctor, yes, I do." But then I have started to say, "Show it to me." And when I say show it to me after they said, "Oh, yes, I carry it with me at all times," then they say, "Oh, it's in my other purse. Oh, it's in the glove compartment of my car." Suddenly it's not with them at all times. So now I have my patients trained that they essentially walked into the office holding their epinephrine, their auto-injectable epinephrine, and showing me that they carry it with them. But the other side of that problem is that physicians aren't always clear about the correct use of epinephrine for anaphylaxis. And so we have to make sure that we continue to say that the delay in epinephrine use is associated with poor outcomes in anaphylaxis. There are no contraindications to epinephrine at the appropriate dose for anaphylaxis. Even in patients with coronary artery disease, which is the question I get all the time, the anaphylactic reaction is more dangerous to them than the use of epinephrine. So the side effects are minimal when it's administered IM at the appropriate dose. And the majority of deaths to anaphylaxis are associated with not using epinephrine or delayed use of epinephrine. In many cases, the patient will need a second dose of epinephrine. Recent studies have shown that between 16% and 36% of patients who receive epinephrine for anaphylaxis will require a second injection of epinephrine. Now, one of the things that the World Allergy Organization advocates for is the use of auto-injectable adrenaline worldwide. And you see in this map from 2017, only the countries in red currently have auto-injectable epinephrine available. So again, I've said that the allergist lives out here particularly in the blue triangle, and we need to focus on our patients' long-term goals. So when a patient comes to us who has had anaphylaxis, we have to partner with the patient to become a detective to try to determine what caused that anaphylaxis. We have to try to assess the cause and the risk for the patient, and to try to figure out what the most likely causative agent would be. And we know that common triggers include food, insect stings, and medications. But we also know that things like latex, our own immunotherapy, cancer chemotherapeutics, and other environmental factors can cause or trigger anaphylaxis, and that there are non-immunologic triggers for anaphylaxis like exercise, cold exposure, radiocontrast material, opioids, and blood products. And we know that sometimes we have idiopathic anaphylaxis where it's difficult to find the trigger or we can't find a trigger. And in those cases, we have to consider the possibility of a mast cell disorder. And one of the things that has really helped us is the use of the test for serum tryptase. We see in this graph that serum histamine rises very rapidly and drops very rapidly, making it difficult to use that as a test. Serum tryptase rises rapidly but falls off more slowly, so that it is a marker that we can actually test for. And so tryptase levels do provide a more precise measure of involvement of mast cells than our clinical presentation. And we can, while the tryptase is elevated for up to 6 hours, typically we try to measure it within 3 hours of the beginning of anaphylaxis. And the normal tryptase should be below 10 or 11. And the higher the value that we have, the higher the sensitivity of our test. Importantly, the negative predictive value for tryptase is not very good. And let's go through this. So if we have a patient who has anaphylaxis, and this graph, this figure comes from Dr. Castal's article that was in JACI in 2017, and this is the second article that I think should be in every allergist's library. What it shows that when you look at a patient who has anaphylaxis and you get a tryptase level that is symptomatic during the symptomatic period, if it's normal, that does not mean that we don't go ahead and continue to try to study the patient to find out what caused the anaphylaxis, because again, the negative predictive value is poor. If the tryptase is elevated during anaphylaxis, one thing that's important to do is repeat the tryptase at baseline so that we learn what the baseline tryptase is. And if that is elevated, we need to then begin to consider the fact that this patient might have a mast cell activation disorder, whereas if the follow-up tryptase is normal, then we test that patient for the normal things that would cause anaphylaxis. It's also our responsibility to educate not just the patient and the patient's family, but all the healthcare providers who may take care of this patient. And I use this particular image in this slide because I want to remind myself how many times I've seen anaphylaxis patients come to me from the dentist's office, and this is a latex dental dam that caused an anaphylaxis that I took care of. So to talk to dentists and our nurses, our front desk personnel, but also other people who come in contact with our patient, like teachers, daycare workers, and colleagues. And so after we've helped the patient by identifying the agent that caused the reaction, we have to go to the reduced risk part of this. How do we help a patient lower his or her risk of future reactions? Because we know in a patient who has had anaphylaxis that 26 to 54% will go on and have a recurrent episode. Well, the allergist has many tools in his or her toolbox. One is desensitization for anaphylaxis to stinging insects. This is a real success story for the allergist, and we can provide long-term protection against future stings in those patients who have had anaphylaxis to stinging insects. We can also provide desensitization for patients who have had drug reactions, but we do not provide long-term desensitization. In this case, we can provide a tolerant time period for the patient to use the medication that is required. But if they need to use it again in the future after that episode of care, they will require another episode of desensitization. So this is not a long-term desensitization. And if you begin to do this with patients, there are a number of protocols that are in the literature. In terms of anaphylaxis to foods, currently in the United States, the FDA has approved only oral immunotherapy to desensitization for peanut. We're looking at a number of other different foods. There are a number of experimental protocols, but peanut is...
A ver, excuse me, Brian, your presentation is not showing. Can you check it that?
Did it just disappear?
Yes, just disappear. Can you check it?
Is it back?
Now it's back, yes.
Okay.
Sorry.
No problem. I'll try to hurry because I want to keep us on time. So typically avoidance is our only treatment for foods, with the exception of now the FDA approved oral desensitization for peanut. Every anaphylactic patient should have a written action plan that tells them how to recognize anaphylaxis and what to do and who to call for help. This is really critical in COVID times. So there was an interesting editorial written by Dr. Casale and his colleagues looking at acute home management of anaphylaxis during the COVID epidemic. And it had this figure. And so the top of the figure tells the patient how to recognize anaphylaxis, but it's the bottom part of this figure that I want to focus on. And the bottom part of this figure shows that the patient should inject epinephrine immediately, but instead of immediately going to the emergency room where the patient may be exposed to COVID, they should notify a housemate or a neighbor to help them. Then they lay down, if they have oral antihistamines, if they have albuterol, they can do them. But what's important is instead of going to the emergency room, they monitor their symptoms at home. And if their symptoms resolve, they monitor themselves for 4 to 6 hours. If their symptoms get worse or don't improve, they repeat the epinephrine, and that's when they engage the emergency medicine system and go to the emergency room. So this is just another way to protect our patients from COVID during this time. So I like this figure that I think that Dr. Simon's 2 triangles need to exist within a bubble that I show here in green, because it's not just the patient and family that needs to be educated, but everybody who comes in contact with that patient needs to be educated. So we know that anaphylaxis is underreported, underrecognized, undertreated, underappreciated, and that current guidelines are underutilized. That anaphylaxis is not just a killer allergy. It's a chronic condition with occasional but potentially severe exacerbations, and we must be part of an overall multidisciplinary team to take care of these patients. Thank you so much. And I'm sorry that the slides went out for a moment.